let's get started. I'll kind of, lead into for those people who don't know who you are, Bryan. Let's give a quick intro for the ones that weren't there last month. Very quickly, who you are, what you're doing right now, what's inspiring you in clinic, and then we'll get going.
Okay. Yeah. So I practice at the East Coast Naturopathic Clinic in Bedford. I've been practicing for 12 years, and my practice primarily focuses on just more challenging or treatment-resistant cases. So I treat a lot of chronic digestive disorders as part of that, like underneath that umbrella, which obviously is why we're chatting tonight. But I also treat a lot of chronic pain, so hence our chatting about or discussing regenerative injection therapies last month, do other treatments for pain as well, but injections are oftentimes what I can bring to the table as a naturopathic doctor. I also work with a lot of patients with chronic infections, so things like persistent Lyme disease or other types of chronic, like say viral infections, things like that. I work with a lot of patients who have a cancer diagnosis. I treat patients with neurological conditions like Parkinson's, Alzheimer's, MS, things like that, autoimmune conditions, children on the autism spectrum. So basically, if it's anything complicated or difficult, then that's what I specialize in, because apparently I want to have as much gray hair as humanly possible, as quickly as possible. And I'm doing a pretty good job. So, lots of gray in there. So that's what my practice is all about. Things that are inspiring me or exciting me these days. There's just always stuff. So there's something new like every week that I get excited about. But the thing I'm probably the most excited about right now is I've just read this really great book. It's called The Thyroid Reset Diet. It's by a naturopathic doctor named Alan Christensen, and he spins a really good yarn, dipping into the scientific literature for everything that he has in his book, about how it may very well be that we are being over iodized in our society. So with the fact that we collectively the royal we add iodine to all of our salts, and there's lots of salt in many processed goods for sure, but even
Mm.
folks who are like say buying Himalayan sea salt or this or that, which I up to this point is like, oh, that's great, it's pink, it must be healthier than regular white salt, boring old white salt. And yet he makes a very strong case to suggest that a lot of thyroid issues might be actually induced or exacerbated by excessive amounts of iodine. So anyways, that's been really fascinating. That's kind of been blowing my mind lately. So that's my most recent thing that I'm excited about.
That's very cool. Always glad to be with people, surrounded with people that read and still want to grow at this point in your practice. You've been in practice for a while, and sometimes it's easy to kind of dive into a rut. And obviously, these patients keep you thinking and on your toes because you don't pick the easiest of cases. So I definitely commend you for that, because that's a challenging way to go about practicing. And every day, you have to deliver on your promise, so to speak.
Mm.
So let's jump into this topic of digestive issues. I think it's a very pertinent one. I think it's a very um, you know popular topic nowadays, because I see it in clinic, and a lot of people have these issues, and unfortunately, a lot of them don't get diagnosed, and they kind of go uh, month after month and year after year with an improper diagnosis. So they don't know where to turn to. So they jump on these bandwagon diets and, one size fits all type of approaches. One of the things that I feel is true is that there's an increase of those issues. And I don't know if it's because of the quality of the food that we're eating, the stress that we're under. I'm assuming that it's a multifactorial problem in terms of why we're seeing an uptick. And maybe we're not seeing an uptick, but I feel we are. Can you comment on that, Bryan?
Yeah, as I say to my patients all the time, I live in a bubble. So, I'm surrounded by my patients and my patient population. Most of them have been struggling for a long time. And then, my wife's a naturopathic doctor, so I'm immersed in that at home as well. We lead a naturopathic lifestyle. I have lots of naturopathic friends. So I very much live in a bubble. But I would say that I would say that it's really quite rare that almost regardless of what a patient is coming in to see me for, whether it's for like they need PRP for their knee, or they have Alzheimer's, or they have an autoimmune condition, I would say that the vast majority of my patients have digestive issues. So like I would say it's very prevalent. And so where I treat a lot of chronically ill folks, or more complex cases, the fact that there's digestive issues, and I would say probably a good 80% of them anyways, either speaks to the fact that there's a digestive root component to a lot of their issues,
Right.
or that their, correlation doesn't equal causation. But I would definitely say it's very prevalent in my practice for sure.
Yeah, that's well said because I don't know, I live in a bubble as well with my practice, and I don't necessarily focus on digestive issues, but obviously within the health history intake process, those issues do come up. Um, one of the ones that I hear a lot about is IBS, right? So this might be a good one to start with, Brian. Enlighten us a little bit about IBS, what it is, and what can be done in terms of testing, because without testing you're shooting blind darts, I always say, right? And you're trying to, to corral your way through a maze, and it's dark and you're not seeing where you're going, and you're kind of grasping at straws in terms of figuring out why you're going through periods of hardship, and then it's okay. And shed a little bit of light on that issue that is IBS.
Sure. Yeah. So with IBS, I mean, anyone listening who has IBS knows what it's all about. But for anyone who's not familiar, so oftentimes there are symptoms like gas and bloating, abdominal discomfort. There's three subtypes of IBS. So there's IBS-C if there's more of a constipation predominance. There's IBS-D if there's more of a diarrhea predominance, and there's IBS-M, which stands for mixed. So i.e. it's
I didn't know
constipation
that.
or diarrhea. Well, you learn something new every day. So those are the three subtypes of IBS, and then there can be other associated symptoms as well. Kind of touching on what you mentioned earlier, Dr. Ben, where there can be a mental emotional component to things. So oftentimes there can be a stress, like with IBS, there can be an exacerbation or an induction of symptoms when the patient or when a person is feeling more stressed. So that's kind of a little bit of a overview of IBS. And then with IBS, it's really quite fascinating because I've had so many patients. Like, well, it's fascinating in that with IBS, there's from just like a mainstream medical perspective, there are certain pharmaceuticals or dietary interventions or like fiber supplements or things like that that do have evidence showing that they can help with the symptoms. But generally speaking, most patients are told when they are diagnosed with IBS, that, like, this is just something you're going to have to learn to live with. Like, there's no cure for IBS, and indeed, like, there is no pharmaceutical that's known to cure it. There's no surgery for it. Granted, there are some patients who, the odd patient who does phenomenally well on a given prescription medication to help with their symptoms, and it might be curative for them, but generally they're told you just have to learn to live with this. And that's a drag in general, and it's
Yeah, no
especially
kidding.
challenging when you're told that when you're, say, like 15 or 25, and you hopefully have another 75 to 85 years ahead of you on this planet. So it's a challenging thing to live with. So it's really, very rewarding when we identify these root cause factors through some testing, or just figuring it out clinically. Not everybody wants to have testing done. Not everybody can afford to have, lab testing done, because the tests that are unfortunately, the tests that I find to be the most useful are the ones that aren't covered through provincial health care. The tests that are available through provincial health care, they're very, very useful. Like, you may need a colonoscopy or a biopsy or whatnot to rule out inflammatory bowel disease like Crohn's or colitis, or, getting H. pylori ruled out, that because that could be a cause of what is maybe presenting as IBS-like symptoms. That can be really helpful. But most of the patients I see, they've already run through the gamut of everything they can do with their family doctor, which makes sense. And then many of them have gone on to see a gastroenterologist, maybe had some additional testing or recommendations there, but they don't come to see me if their gut's already been fixed. So I see the
Right.
folks who haven't been fixed yet. And so in those cases, they've kind of tapped into the testing or treatments that are available through the healthcare system. And if they're not 100% better, then we have other tests and things that we can work with, thankfully.
So IBS, irritable bowel syndrome, like it's kind of general, right? So what could be the potential irritants that would create that inflammatory state? Like we hear about like leaky gut and how the gut wall can become eroded or irritated. So let's talk a little bit about that in terms of what could be the potential causative factors that could create that symptom.
Yeah, so kind of reverse engineering the whole process of, kind of looking at, well, what kind of things have resolved the IBS symptoms, or like put it into remission, or whatever kind of language you want to use. So in some cases, it is, as simple as a diet, and, changing your diet. not the easiest thing. Some have said that changing your diet is harder than changing your religion. So, like, it's a little maybe a cheeky thing, but that some people have said that. And for some patients, I can say it's probably true because they really don't want to change their diet.
Yeah.
And sometimes it's as simple as, cutting out gluten and then their IBS goes away. And gotta love those cases because, like, how easy is that?
Yeah.
Unfortunately, where I'm at in my career, patients who come to see me have already done gluten-free, dairy-free, sugar-free. They've been on a low FODMAP diet, paleo diet, keto diet, low oxalate diet, low salicylate diet, low lectin diet. Like, they've done everything, and then they're still not better. And it's like, oh, great, that's not going to be as easy as just cutting out gluten. But food triggers can be huge. Stress can be a big factor as well. And what I see a lot of in my practice is we do this functional test to determine if somebody has low stomach acid, and oftentimes they do. And it can sometimes be pivotally beneficial for them to work with something to help boost up their stomach acid level. And and sometimes, like, they've done lots of other treatments and tests and this and that, and it's the stomach acid that makes the biggest difference at the end of the day. It's like, wow, like, how simple is that? But what's one of the biggest drivers for depleting your stomach acid? I mean, aside from advancing age, so granted, as we get closer and closer to 100, our stomach acid, slowly goes down. But that being said, plenty of octogenarians in my practice and their digestion's just fine. So it's not a, guaranteed thing. That is one immutable factor that will start affecting stomach acid levels. But the other big thing, at least in my experience, that can affect stomach acid is stress. When we don't get into that parasympathetic relaxation, rest and digest mode, then it really, really does impact and impair your digestive capacity. So I have a lot of patients who are just like type A, or they're anxious or this or that. And, they're like, yeah, I'm doing all the right things diet wise, and I'm treating my microbial overgrowth in my gut and some of the things I'm sure we'll talk about coming up soon. And yet, like, I'm still not 100% better, and my gut's still so touchy. Get them on a stomach acid supplement. And sometimes it just makes that all go away because they're just literally not able to get into that restful enough state, that calm enough state where they can actually make enough stomach acid to break their food down. Stomach acid is not technically not the first step in the digestive process, but I would say it's certainly the first most impactful step in the digestive process. If that's not present, you're just really setting yourself up for failure, digestion wise.
That's really cool.
So a couple of weeks ago, Dr. Ray, we had a conversation together about the idea of sleep. And so we were talking about how these patients just aren't able to get into that parasympathetic state.
Mm.
And so do you find that there's a connection between people who have a condition like IBS or other stomach issues and a lack of sleep?
Like sleep apnea, right? Be a good example.
Yeah, I mean, definitely, I've definitely seen a correlation with insomnia. I'm not, I don't know if I can say with sleep apnea specifically per se, but definitely insomnia, and whether that's being contributed to by sleep apnea or caused by sleep apnea, that
Right.
certainly could be a case. But I would definitely say, like, the folks that have a hard time getting into that rest and digest mode, like, so they have a hard time with the digest, and then they have a hard time with the rest, to be able to fall asleep and stay asleep. So there's this constellation, sort of picture that I I did this 2-year fellowship program 5 or 6 years ago now, with one of my colleagues in something called endobiogenic medicine, which is kind of like the French version of naturopathic medicine. Naturopathic medicine is really a North American phenomenon. In Germany and Switzerland, they have something called biological medicine, which is kind of their version of naturopathic medicine. Endobiogeny is kind of a French version. So, and just as a point, trivia question, if you're ever playing Trivial Pursuit, if anybody actually remembers what Trivial Pursuit is, if that question comes up, that's endobiogenic medicine is the French version of naturopathic medicine. So I did this 2-year fellowship, and one of the most useful things I got from that whole program was learning about something called alpha sympathetic dominance, where these are the folks who kind of get into like this, they're just revved up. Like, sometimes they're physically revved up where they have like heart palpitations and they're just kind of jittery and they get muscle spasms and like they just can't calm down. But they can also be very mentally revved up as well, where like they just have a hard time
Yeah.
sleeping, they're ruminating a lot, they're worrying about things, like a classic worry wart type A, like person who says like, what's a couch? Like, I never sit on a couch to watch TV. Like, I'm
Yeah.
always
Those are the
cleaning
ones
or
in your waiting room that just never sit down.
There you go. Yeah, the pacers. And so those are the folks where it's very common that you'll see, the digestive issues because they're not getting into the rest and digest from that perspective. They're having trouble with sleep. They have anxiety, and oftentimes their adrenal glands get burned out, like they have adrenal fatigue. Over time, like they're the Energizer Bunny through the day, but then as soon as the stimulus goes away, they just crash like nobody's business, or they're great during the work week, but they crash on the weekend. So that alpha sympathetic pattern, that kind of constellation of like digestive issues, sleep issues, feeling kind of stressed, having a hard time relaxing, it's a really common pattern that we see, and it's hugely important for those folks to work with things to help calm their nervous system down because we can treat really downstream and take the stomach acid, treat the microbial overgrowth in the gut, change the diet, maybe work with certain things like GABA or 5-HTP or things to help calm their nervous system down, melatonin at nighttime to help them sleep, or valerian root, or whatever it happens to be. But ultimately, it really and that can really help symptom wise. But it's all stemming from inside of them. It's their like that the underlying factors that are
Yeah.
ramping up their alpha sympathetic nervous system, and so that's where sometimes it's we got to talk about like work life balance. We have to talk about maybe some cognitive behavioral therapy, maybe work with like a psychologist or something like that, just to kind of help with that. If we really want to get to the root cause aspect of things, that sometimes is necessary in those patients.
Mm.
So you go through the inventory of what they've done. So if somebody comes in with you to you, Dr. Rade, and they have IBS, you take an inventory of what they've done. If they've tried the gluten-free, dairy-free, all the stuff, get a sense for their lifestyle, and then that helps you determine where you're going to start with that patient, potentially with testing, whether it be whatever bowel testing you're going to do, and then based on the results of that test, then they can guide you towards whatever treatment plan you're going to do and recommendations. Correct?
Yep,
Okay.
exactly.
And most of those tests, we'll talk about that maybe a little later, but a lot of the ones that you're going to do obviously haven't been done from a medical standpoint, and which is why they're coming to you. So a lot of them, and I know this from our family when we've seen you, a lot of them are not covered, but they're not, you're not talking about a $4,000 test either, right? So a lot of them can provide a lot of great information that, again, unfortunately, it's not going to be provided most of the time by the regular medical testing per se, like a gastroscope or whatever they're going to do, right?
Yeah, yes, absolutely. And I mean, with the testing, like just to give folks listening a sense of it, because like not expensive, is that $5? Is that only $800? Like what does that
Yeah.
mean? So just to kind of give a rough sense, like a very common test that we do is this called a lactulose breath test, which assesses for this condition called small intestine bacterial overgrowth, and that's going to range, depending on which clinic somebody goes to and which lab they're using and this and that. But like so I'll just speak to the prices at our clinic, just because I know what those are. And so that's like $120 to do that test.
Mhm.
Or if you're going to do a stool test that might look for, large intestine bacterial overgrowth or yeast overgrowth in the gut, or we want to get a sense of probiotic levels, like there's a combination test that does that. There aren't any Canadian labs that do that testing, so the prices are in US dollars. With those labs, some clinics do you pay the clinic directly and then they pay the lab. At our clinic, we don't like getting involved in that at all costs, really, because quite frankly, the test, if we just don't, well, anyways, we just don't like to get involved with that. We figure, what, patients are paying us for our services. You can pay the lab directly. We don't want to get involved. We don't make any money whether they do the test or not. We're
Yeah.
happy with that. And so with that type of testing, it's $107 US. Or if we want to do like the big daddy of all stool tests, something called a comprehensive stool analysis, that's going to look at the probiotic levels, the bacteria, the yeast, but it's also going to measure a bunch of these, what they call stool chemistry parameters. So it's going to tell us about the level of something called short chain fatty acids, which is a fuel source for the intestinal cells. It's going to tell us about something called secretory IgA, which is the main type of antibody that's produced in the intestinal mucosa. So if that's really high, then that might be an indication that the gut's really irritated or being attacked by something. If it's really low, then it might mean that the patient's gut is more susceptible to damage, or rather microbial overgrowth, or it might be that they're not producing enough bile in their liver and being excreted by their gallbladder, because you need bile in order to make secretory IgA, for example. The test tells us about how well they're digesting their carbohydrates, their fats, and their proteins. There's inflammatory markers. So we can get a lot of really great information from a comprehensive stool analysis. So a test like that, which is quite a bit more comprehensive, that's 230. I think they just actually increased the test by like $10. So I think it's $235 US now to do that. So like it's a good chunk of change, but it's not like several $100s, thankfully.
Yeah. And for somebody who's been going down this rabbit hole, time and time again, that is a small exchange, in terms of being able to find out information that you didn't know about your gut prior, that probably has, impacted your life for 15, 20, 30 years for some people, and shedding a little bit of light on what could be done to rectify the situation. So guys, I don't know how you're feeling about this, but I think it's good information. I've learned something already. So just give us a few thumbs up there if there's a little liking going on here with what you're hearing. A little question here: is there a test for stomach acid levels?
So yes, there is. There is kind of an official test that can be done for that, and it's a really, really cool machine that's used. I've honestly like had it on my wish list for a while, but the functional test that we do instead just works so well. I just haven't been able to justify buying this machine. It's expensive, but anyways, there's something. It's called a oh my goodness, I'm blanking on the name. I think it's called the gastro scan. But basically, what you do is you swallow this a pill that has some type of like a radio frequency emitting technology in it, and then a scanner is put over top of the person's stomach, and the pill sends data about the pH, so the acidity level of the stomach as it's sitting there. And then what's really, really cool about it is that you can actually then track the pill, because what goes in one way must come out another way. And so about I think 20 minutes after they swallow it, then they can actually use the tracer over top of the patient's abdomen to actually track it as it's moving through the intestinal tract, and you can get a sense of the motility of like the transit time of the gut, the acidity level in the small intestine, and this and that. So that's the best test. To my knowledge, no one's offering that in Atlantic Canada. And when I
You
looked
would be the
into it,
first one.
I would be, I know, and that's the other
And
draw, right?
I would consider you amazing if you had that test.
I will put that in the list of motivators to spend the money to buy that machine. But honestly, like, I have lots of tools and toys. You could ask my wife. You should interview my wife at some point and ask her how much money I've spent over the years on gadgets and gizmos. Because I have no hobbies. I just you're a gadget guy too. Yeah. So that's why we get along so well. And so just the cost of that little fancy pants pill that you swallow, the cost of consumables for that, it's like about $150 per test. So it's either that or we do this free, because we just have we give out the material for free to do the functional test, which I'll describe in just a minute. So it's either like I could ask patients to spend $150 to do this test, which granted is really cool and fancy, and granted, going to give us like really precise info, but the functional test is $0 and it works really, really well. And that's what I've been doing for 12 years in practice. So I haven't been able to justify that, getting the machine, but the functional test is and bearing in mind that nothing that I'm saying right now should be construed as medical advice or me, asking anybody to do this, but just for information's sake.
This is all medical advice.
What was that, sorry?
This is all medical advice.
Okay, well, I'm going to say what I'm saying is not medical advice. Contrary to what Dr. Roach might say, this is not medical advice that I'm saying, at least. So basically, it's a test where a patient takes a capsule of stomach acid. So we have an open bottle at our front desk. So we just give out a few capsules in little packets to patients. That's why it's a $0 test at our clinic, at least. So we give them a few capsules, and then basically they take a certain amount of acid. I'll be a little elusive here, so I'm not my college won't get mad at me for saying this. So it's not construed as medical advice. But basically, they take a certain amount of stomach acid capsule at a certain time, and then depending on their response to that, basically whether they feel nothing when they take it or they get heartburn from when they take it, And I won't say whether it's with or without food. So anyways, please don't do this at home, kids. But unless your naturopathic doctor or somebody else prescribes it for you. But depending on their response to that, then that gives us very useful clinical insight into whether they have low stomach acid or not. And I found that to be incredibly predictive and very accurate. And that's why I just have not been able to buy the fancy machine. But that's the functional test to determine if someone has low stomach acid, also known as hypochlorhydria. And hopefully that answers the question.
Cool.
Great
Great
question.
segue into the next topic. Heartburn, acid reflux. Go.
GERD.
Yeah, so in terms of things that can drive that, so I mean, foods are like food triggers can be huge, and quite frankly, I've had many patients who come in and they say like, oh, like I've got IBS, and like, oh, and I had my intake forms, as I'm sure you folks have it too. It's like, do you have these conditions, and if so, are they present? Like, do you have this, or you don't have this, or have you had it in the past? And so they'll say, oh yeah, I had heartburn in the past, and like, oh, like, what? How did that go away? Like, oh, I just stopped eating certain foods that my family doctor or my nutritionist or my gastroenterologist told me to avoid, and like my heartburn's gone, but I still have my IBS or whatever it is. And so foods like chocolate and spicy food and tomatoes, particularly cooked tomatoes, anything like really acidic, like orange juice, that kind of stuff. So food triggers can be huge, but there can be other food triggers too. I've had patients who go gluten-free or go on a paleo diet or things to that effect, and that resolves their heartburn in some cases. And then I've had many patients where we need to, either ideally test for or at least do a therapeutic trial treating for something like small intestine bacterial overgrowth, which is a really common correlation or common thing rather that I've seen in the really challenging cases of heartburn or reflux. It's not to say that every case of heartburn or reflux, if we find SEBO, it resolves it, but that's oftentimes a big trigger. There can, of course, be mechanical factors, which you guys could talk more about than me in terms of like hernias and this and that. But yeah, in terms of things that I see in my practice, oftentimes it's food triggers and microbial overgrowth in the gut.
Dr. Reed, I know like I treat a lot of kids as well in my practice. And one of the things with newborns is, a lot of them are often diagnosed with reflux, right? So they can't keep, the breast milk down. Or do you see that a lot in your practice? Is that oftentimes not necessarily misdiagnosed because they may have it, but in terms of the cause, it's not really, I would say it's not really pushed to figure out why is it happening, I guess is what, I'm concerned about.
Yeah, I have seen many cases of infant reflux
Yeah.
over the years, and I have found that I don't even know if I can think of a case where when we uh, it was either a food trigger or maybe we did like a stool test on the little one and found that there was like a yeast overgrowth or something like that.
Sure.
Oftentimes with kids, like you can really tell clinically, it's like, oh, mom's having you know yeast infections
Yes.
like
Yeah.
around on her breast. It's like, okay, then the kid has maybe yeast in their gut, and so we don't even need to test sometimes.
Right.
But yeah, it's really really common that I find that those cases are very amenable to treatment.
So Nexium and all these pills like proton pump inhibitors,
Mhm.
are you concerned by those?
I'm a little bit concerned by them. I mean, when you really dig into the literature on them, like to my understanding, there are some studies that show that being on them for a prolonged period of time, might increase the risk of certain health conditions. It might cause a vitamin B12 deficiency, might be associated with certain types of cancer, might be associated with, high risk of osteoporosis. To my understanding, when those studies like really have their feet put to the flame, so to speak, it's not like hard and fast definitive evidence. So if you really kind of look into it deeply, it's not necessarily like a huge risk. But I do think that at the end of the day, if we can avoid fiddling with natural physiology and a patient can feel good without needing to fiddle with it, that's
Yeah.
probably the best thing to do. Because, to date, I haven't seen any literature out there looking at, oh, like if I'm on Nexium for 25 years, like, how does that impact me? It's like I don't believe they've done studies that long, and some people are on it for like 40 years. So
Forever.
I think there's still some unknowns there. And so it's like, well, like, what does Nexium do? It inhibits your ability to make stomach acid. It's like, well, your body wants to make the stomach acid. It's doing it for a reason. So maybe we should try to fix the problem so you hopefully don't need to be on the Nexium.
Yeah. I had a patient one time, and not a patient, sorry. I had a conversation with a doctor, and then I kind of relayed that information to the patient. And I might confuse people here, but and maybe I'm the one that's confused, but uh, if I understand correctly, acid reflux is actually a problem of the stomach not secreting enough acid. Is that correct?
Yeah, it's a really good question, and in my practice, I've seen many cases where the reflux got better or went away when we put them on stomach acid. So it's like, oh, it must be a deficiency, and
Right.
yet there are certainly cases though where the patient goes on stomach acid and actually really exacerbates their symptoms. And in those
Yeah.
cases, I do wonder, is that because they have some underlying gastritis and just the extra acid is just too harsh on their stomach, or maybe their esophagus is just so cranky that the stomach acid, if it is refluxing up a little bit, it's causing an aggravation of that tissue. But yeah, I've looked, I've spent, I don't have a social life, so I spend a lot of time looking at studies and things like that. PubMed is my home away from home, looking at, which for folks who don't know, it's a database of like every study ever done pretty much. And I have not been able to find a study looking at the link between low stomach acid and reflux. So there are theories that have been like kind of pieced together with supporting evidence from the research literature, but I haven't found any distinct literature to date saying that there's a causal link there between low stomach acid and reflux. What is of interest is that the incidence of reflux goes up over time, and the ability of our, as I mentioned earlier, our stomachs to make acid goes down over time. So that's some interesting correlated data or info. But I have found that in a lot of cases, it winds up being a low stomach acid issue.
Okay.
So just switching gears from condition to condition here, moving on. I was wondering if you could speak a little bit to celiac disease and what patients can do for themselves, or is it just simply adopting a gluten-free diet? And here we go, we're rolling now. So what
Mm.
can patients do to help manage some of those symptoms other than adopting a gluten-free diet?
Yeah, that's a great question. So yeah, with celiac disease, for folks who are diagnosed with celiac disease and they cut out gluten and then all of their problems go away, in my opinion, that's like all of their digestive problems anyways, maybe not life problems, but anyways, digestive problems at least. Then in that case, it's, you know, problem solved, open and book or open and shut case. Like you're just, I think, probably good to go. You probably don't need to do anything beyond that. Where but then there are some patients where, and I would say it might be like, in my experience, maybe like 30% of the time, maybe 20% of the time, they'll say like, oh, I was diagnosed with celiac disease. I've stopped eating gluten and I'm not all the way better. Like I'm better, but I'm not all the way better. I still have significant symptoms. And in those patients, a lot of them have that small intestine bacterial overgrowth condition that I mentioned. So it's really, really common to see that in those patients. And what's
Mm.
really interesting, just a little bit of history, and I forgive me, I don't remember all the exact details, but the punchline, anyways, is that back in like the 1920s or something like that, a long time ago, there was this issue where kids would have celiac disease and nobody knew what it was at the time, and like the kids would get really sick and die, and it was really, really awful, obviously. And so there was this doctor, and I don't remember his name, but he developed something that became known as the banana diet, because kids were it was a very strict diet. A lot of the calories came from eating bananas, hence calling it the banana diet. But
Really?
basically, it was it wound up being it was gluten free, which is why it worked so well. But it was also very, very low in complex carbohydrates, which are the main food source that feeds the SEBO bacteria. So he was putting people, kids on the banana diet. They were doing great. And then over time, it eventually was discovered that, oh, it's gluten. And then the banana diet fell out of favor because it's a lot easier just to cut out gluten than like a bunch of other foods and eating tons of bananas. And so I just think that little bit of history is really interesting, because he actually kind of like, biohacked an anti-SEBO, anti-celiac diet, And I think that's really interesting because, as I mentioned, some folks with celiac, it is more complicated than just the gluten.
Hmm. Yeah, and
That's
I just
very
thought I would
interesting.
speak to that. Yeah, I wanted to be able to just sort of bring that up because I know that there are a few select people that don't respond completely to the gluten-free diet. And so definitely there's some folks that are watching here tonight, and celiac disease is just so common. I mean, I feel like it's so common. Everyone's
Yeah,
trying to get on a gluten-free diet now. And so it's great that you can speak to that. So thank you so much.
yeah, my pleasure. So what I'm here
Um,
for.
there's a specific question regarding a patient's case. Let's continue this conversation if we have time. And I'm sure you guys can appreciate this. Like, it's hard for us to have a case and say, well, this happens when I do this, and I have this, and I have that. But it kind of takes away from the whole process of actually sitting with a person, looking at the whole picture. And we kind of can't give medical advice, as you've alluded to earlier, on a specific case. So it's hard to answer some of these questions. Um, this one I can answer. I can ask though. Do you agree with the new advice out there that SEBO diets harm the microbiome?
Um, I would not agree with that. Um, I and the reason I say that, and I mean SIBO diet, like that's I guess the question would be like, what is that specifically in reference to? Like an anti-SIBO diet could be a low FODMAP diet, it could be a GAPS diet, it could be a specific carbohydrate diet. Technically, could be a keto diet. Technically, could be a carnivore diet. So it would really kind of depend on what diet it is.
Dr.
Um,
Ray, just hold on. This is SEBO. For the people that don't know what SEBO is, it's called
mhm,
small intestinal bacterial overgrowth. So just so
mhm,
that we're saying this word, no, somebody's lost there. So go ahead. Sorry.
mhm. Sure. So with those diets, I would say that like I've had patients on who have been on all of those diets, either by my prescribing it or somebody else or them self-prescribing it or whatnot. And I haven't seen any patients develop digestive issues or other health issues that would be indicative that they might have a compromise of their healthy microbiome after having been on those diets. And so, from my clinical experience at least, I don't think that it disrupts the microbiome. I think our microbiomes are really quite adaptive, and it's really quite fascinating where when they do studies looking at the microbiomes of different folks who eat different types of diets, like whether it's more of a plant-based diet, whether it's more of a carnivore, like a meat-based diet, whether it's like more of a truly balanced omnivorous diet, like they have totally different microbiomes. But when you go from eating one way to another way, or like kind of back and forth, like your microbiome shifts as you go along. So I think as long as you have a pretty healthy microbiome to start with, then it probably doesn't really matter what you eat as long as don't eat junk food and things like that. But your gut should be really adaptable. Like as human beings, like evolutionarily speaking, it hasn't been that long that food has been just like a guaranteed like pop over to the grocery store, you buy whatever you want. We had challenges, evolving up to this point as a species. And so like our guts had to be really adaptable. And so I don't think that shifting a diet, even if it's like an extreme diet, like a carnivore diet, for example, even for, maybe in a few months, like I don't imagine that would cause a negative shift in the microbiome. I haven't seen it. I certainly haven't seen any studies looking at that. So that's just based on my clinical experience and opinion.
That's a great answer. And she was satisfied. She said, thank you.
You're welcome.
For those of you just joining in, or if you're on YouTube, which means that you're not live and it's the following day or whatever, just make sure you subscribe to our YouTube channel. For those of you who are joining now, this is Dr. Bryan Rade from East Coast Naturopathic Center. It's our 30th episode. Once a month, we do a live guest interview. And tonight we're talking about digestive issues. If you've enjoyed this so far, make sure you give us a thumbs up. I want to segue a little bit, but still condition based. So we've talked about irritable bowel syndrome. We've talked about celiac just a second ago. We've talked about acid reflux. Before we go into kind of the conclusion and stuff like that, what would you say would be the number 3 or number 4 digestive issue that you see in your practice that's pretty prevalent nowadays, Dr. Ray?
I think in terms of prevalence, I would say kind of a toss up between nausea and constipation, but I'd say constipation would like it for the more like for the folks who aren't like really, really sick, it'd be definitely constipation would be more prevalent, I think, than nausea. So maybe I'll pick that one. Yeah, I'll take constipation for 200, please.
Constipation.
Yeah. So the in terms of constipation, there are a lot of different factors that can affect that. With I mentioned earlier, like there's the IBS type C, so like the constipation dominant IBS, the small intestine bacterial overgrowth that we've touched on a few times now. There's actually 3 subtypes of that one, and one of the subtypes is where the bacteria are overproducing this gas called methane, which happens to be like when you think of, well, hopefully people don't think of this too often, but if you were to think of like just classic like stinky bowel gas, that's like the methane smell usually. Now, if it smells like rotting eggs, that's more hydrogen sulfide. So there's, and now you learn something else new. So classic stinky gas is methane. Smells like eggs, hydrogen sulfide. Now you know. So methane gas is associated with a reduction in the motility of the gut. So it actually precipitates constipation, which is really tragic because one of the biggest things that can encourage small intestine bacterial overgrowth is poor gastrointestinal motility. So methane dominant SEBO is actually kind of like a self-fulfilling prophecy, because constipated tendency could lead to that SEBO. The methane can make you more constipated, and then it just can be hard to get out of that cycle without appropriate treatment. So constipation can be triggered by, so it could be related to IBS, could be SEBO related, could be due to eating just a inappropriate diet. Now, folks listening might be thinking like, oh, he's going to say like a low fiber diet, and fiber is really interesting because, granted, some folks certainly do find that, like, they take their Metamucil or Psyllium or like whatever. Well, Metamucil is Psyllium, but they take their fiber supplement, like, oh yeah, I just have amazing bowel movements, and that's great. Keep doing that if it's giving you amazing bowel movements. It's a beautiful thing. Don't stop. But there's some interesting research to suggest that fiber doesn't necessarily actually have the bowel movement promoting properties that are kind of stereotypically associated with it, at least not for everyone. So just as a point of interest. But sometimes eating the wrong type of diet can precipitate constipation. Stress as well. So everything that we talked about earlier with that alpha sympathetic dominant type, just not getting into that rest and digest mode, that's a great way to develop constipation. And there's other factors as well, but those would be some of the big ones that would drive it.
Dr. Rade, you mentioned nausea as well. How would you explain somebody getting up in the morning and having that nausea, like to the point sometimes like waking up in the middle of the night, vomiting, or feeling very nauseous in the morning?
Mm-hmm. So yeah, it can be due to a few different things potentially, but the most common thing that I see is actually being related to low stomach acid. And I've had just like probably a few hundred cases over the years where that more like it's when somebody tells me like I have nausea and like it's mostly in the morning or maybe in the wee hours and it's bothering me first thing in the day. I never wish any symptoms on my patients, but when I hear that, I do a little happy dance in my head because it's like I'm like 99% confident I know what the issue is for you. And then we, test and find out, yes, you have low stomach acid. It oftentimes makes a huge difference for people. So that would be the most common, by far the most common cause of that I've seen. Of course, we have to know or figure out like what's causing the low stomach acid and all of that good stuff. But just even symptomatically, it can make a big difference for that symptom even before we get the root cause all figured out.
And is that a supplement or just dietary changes?
So I mean, in terms of getting the stomach acid levels on track, I would usually recommend the stomach acid supplement so that we can get the levels boosted up faster. But it could be done through diet alone. If we found that the patient is eating the wrong types of foods or eating a SEBO friendly diet, so it's perpetuating the SEBO. You could do it through diet, but I would usually recommend the supplement in addition to
that's very
the
cool.
root cause stuff. Mm-hmm.
Right. And so there was another question asked, and this may speak to the exact same question that you just answered about nausea. And maybe along the same lines would be something like seasickness. And so someone had posted in the comment section about someone that they know who travels out to sea often, and they oftentimes will get seasickness out there. Is this something that you see in the practice, Dr. Rade, at all, that some of your patients would struggle with?
Well, my nautical clinic, I see that all the time. No, just joking. I have not treated patients for seasickness more than like a handful of times, and yeah, it's not something I could really shine a whole lot of light on. Some people like, work with things like ginger, or they just, take Gravol or something like that, or there's these things you can buy at the drugstore called C-bands, which are like little wrist, it's like oh my goodness, kind of like a bracelet, or a wristband. That's the word. And it's got like a little piece of plastic, and you put it right about here, and it pushes on this acupuncture point called pericardium 6, and that helps some people. Some women use it when they have morning sickness. But yeah, I'm not a seasickness expert, unfortunately. So.
Oh, Dr. Ray, one of the questions I get a lot when people are in our clinic are purchasing like a probiotic, what would be your minimum, like if you're going to buy a probiotic in terms of number of strain, because you see them 4 billion and then 10 billion, and what is your take on that in terms of a general probiotic? And do you feel that most people should be on a probiotic just because we typically may not eat a lot of, fermented vegetables and stuff like that would create a natural, diverse microbiome?
Yeah, that's a great question. So I I have seen a number of cases over the years, and more in my earlier years of practice when I was getting more like I wasn't getting a lot of the hard, like I've seen everybody, and I'm desperate kind of cases, and I had, in many cases in my earlier years where, just maybe a little bit of dietary tweak, go on a probiotic, and like all their digestive symptoms go away and everything's just beautiful. And so that it can be really, really helpful for folks. In my practice now, what I have found is that there's the occasional patient that does really well with a probiotic, but like it makes a significant difference with their symptoms. But I find that for a lot of the conditions I treat, like whether it's, like the IBS or the reflux or nausea or whatever it happens to be, like I find it's somewhat hit and miss whether a probiotic makes a big difference. And almost everybody who comes to see me is either on a probiotic or has tried them at least. And so I ask that question of like, oh, you're on a probiotic, like what changed when you went on that? And sometimes it's like, oh, like I don't get UTIs anymore. Like, oh, it does help me to be more regular, this or that. And if it does, that's great. But a lot of the times, like I'm just on it because like before I came to see you, I went to the health food store and, picked up a probiotic, or I saw a podcast or heard a podcast or whatever it was.
Mhm.
So it's not like I really wish it was like a panacea across the board, but it just in my practice, again, more complicated cases, it's a little bit, it's more of a niche kind of population that I work with. In terms of the numbers, or actually what I will say is that with probiotics, where I do find them to be very, very helpful is if a patient needs to go on an antibiotic for some reason, I absolutely put them on quite a robust dose of probiotic. I won't say exact numbers for reasons mentioned earlier with not wanting to give anything construed as medical advice, but I would definitely um, uh, be thinking something like above the number of like 50 billion per day, like for something like
Mhm.
that. And then the other patient populations that I've seen who really benefit from probiotics are folks who have had like say like food poisoning that they just never recovered from, or folks who have like C. difficile, like Clostridium difficile, or folks who like went on an antibiotic and just have had digestive issues since then. Like that's been really, really helpful. It can be, sometimes curative for some cases. I don't recommend that all my patients go on probiotics. I think it's fine to be on them, but I'm just really a results driven guy. And so I've asked my patients this question all the time. It's like, oh, you're on this thing, whether I prescribed it or somebody else did, or they picked it up of their own volition. And just say like, is this making a difference? And like, if it's not making a difference in a reasonable amount of time, then I recommend that they drop it like a hot potato.
Um, I think I lost my train of thought. The probiotic. Do you have to wait till your antibiotics are over, or can you take it at the same time?
Um, so the approach that I take, because I have not yet found a research study that's looked at that question to tell us like, what the right answer is. So just based
Yeah.
on what I've seen clinically is that um, I have not seen there to be an interfering effect from taking a probiotic with an antibiotic. And I've found that when folks take probiotics at the right dose along with their antibiotics, like I can't think of a case where like they developed a yeast infection, a UTI, antibiotic-induced diarrhea thing. Like as long as they're taking the right dose, like it's very, very protective. And I think it makes all the sense in the world to work with them at the same time, because if granted, like lots of folks go on antibiotics, no problems at all. There's no obvious problems, like their gut's just
Yeah.
fine. But you never know if it's going to be that fateful time where it does cause a problem. So, to my mind, it's like, well, if the antibiotic is decimating your good bacteria in your gut, I probably don't want to wait until that 2-week course is over before I start then, picking up the pieces. It's like,
Great
well, let's
point.
just protect those poor little critters, at the same time. And it does not seem to interfere with the efficacy of the antibiotics in any way, but that's the way that I approach it.
Yeah, that's great. I always wondered because again, 14 days, I was like, man, the gut's being destroyed, and they go on
In
a
some cases,
rebound
yeah.
infection, and they're on and off and on and off the antibiotics, and
Mhm.
yeah, it's killer.
It can be, yeah.
Yeah.
So, for everyone who's liked this conversation tonight, who's been here listening with us from the beginning to now, or maybe you're just starting to listen right now, this is Hump Day Conversations, and that's Dr. Bryan Rade from East Coast Naturopathic Center. So, for those of you who like this, give us a like right now, some love. This is a conversation that I'm sure a lot of people will benefit from. So, make sure that you're liking and sharing the conversation as well, so that this information is getting out there to those who may need it, and for those who might need the help of Dr. Bryan Rade at his clinic in Bedford, Nova Scotia, Canada. So, yeah, great conversation tonight.
I have one more question, Dr. Reed.
Sure.
One of the things that I see a lot, and because it's got a link with musculoskeletal problems as well as colitis, and the reason I say there's a link, there's many reasons, but a lot of the people that I see with colitis, they come and see us, they have back pain. One of the things that they've been using to manage some of the pain is Toradol. Have you seen in the literature a link? Because there was a documentary on NHL players, instead of using Percocets and a lot of the opioids to manage their pain, they went to Toradol, which later has been found to affect bowel issues and specifically colitis. Have you seen that in your clinic, Dr. Rade?
I haven't. No, that's really interesting, but no, I have not seen that link.
Okay. Yeah, so they're listing medical journals and stuff on that documentary and how it was linked and how it's become a little bit of a, you have to use the word pandemic, but a lot more people suffering from colitis because of the effects, long-term effects of Toradol.
Yeah.
Anything else you want to offer, Dr. Rade, in terms of digestive issues and people that have these long-standing issues? The number one approach they can take, the first step, so that we can kind of chunk it down, everything we said tonight, the number one step that they could take, and then how to move forward with you if they decide to do so.
Sure. And sorry, just to clarify, like the number one step they could take with respect to what exactly?
Well, what's the first step in terms of having them, contact you and how this works and all that stuff if they decide, okay, this is it, I've been everywhere. How do I do this? And how do they get in touch with you? And how does that all work?
Oh,
Do
sure.
I need a referral to
Okay,
see you?
sure. Yeah, good question. Yeah, so you
Yeah.
don't need a referral. I mean, there are some insurance plans where you need to have your medical doctor write a referral note to access the private insurance coverage to see a naturopathic doctor like myself, but that's relatively few and far between. You just have to check with your private insurance if you have it. Yeah, generally just calling the front desk or emailing. So our email address is just eastcoastnaturopathic@gmail.com. We're also on Facebook under East Coast Naturopathic Clinic. You can look me up on Instagram or Facebook, just it's Dr. Bryan Rade. And so just contact the front desk and then they'll kind of take it from there. It's really handy if you have had testing done or imaging or this type of thing, just to let us know, and we can always requisition that information in preparation for the appointment. And then also it is handy because I'll be asking you if you do come in to see me, just having like a little list of the things that you have tried working with. And ultimately what I'm going to want to know is, what have you tried? And then that, next question would be like, so did it help? Like what happened? Did it make you feel better, worse, no difference? what kind of diets have you tried, etc. Because as I'm also fond of saying a lot of things, fond of saying this too, um, the even if a patient has tried like a million and one things before they come to see me, and like even if nothing has helped, it's like, well, the silver lining to all that is that at least it gives me a heck of a lot more information. Oh, you did every single diet under the sun. Well, now I know that it's definitely not a diet thing that's primarily driving this. So that saves us a whole bucket load of time. Oh, you've been treated for SEBO already, and like your test results have normalized, and you're still not feeling all the way better. Well, at least we're not going to waste your time going after SEBO right now. So it's really handy to know what's been done, and that's just really the most crucial thing with like a good intake is just knowing like what has a patient done, like what's helped, what hasn't helped, and then we can kind of narrow things down. And then for patients who haven't done anything, like, oh, I just didn't know that there was something I could do for my IBS because I was told 15 years ago that I just have to live with it. And you've done nothing. It's like, okay, we can figure that out too. We can always start from scratch, and that's okay. And that's where the testing comes in and this and that. So, but yeah, that would be the first step.
Dr. Rade, have you seen over the years like an increased interest from the medical field in what you do? Like I hear that like frustration a lot with patients. They say, "I wish, we could all, come together and talk about my case, and the doctor be, okay with me seeing the chiropractor and understand what you're doing, and naturopath." And are you seeing a growing interest and an openness and I don't know, an acceptance? I hate to use the word because, anyway, are you seeing that changing?
I'm not sure about general trends. I know in my own personal experience, I've had the opportunity to connect with several medical doctors over the course of time here in Nova Scotia, and so like the numbers growing in that, like it seems like every maybe year or two, like I'll connect with one and we get along really well, and there's a nice synergy there. So from that perspective, like there seems to be a trend in the right direction, but I'm not really sure about general trends or
Yeah.
not. What I will say though is that when there is actually that opportunity to like chat and collaborate, whether it's with a pharmacist talking about like proposed things to work with alongside a chemotherapy regimen, or it's I have a patient right now who we're trying to figure out like what the heck is driving like this chronic kidney disease, and me and the pharmacist both think that it might be like one of the like 15 meds that the patient's on. So like we're collaborating a bit, and then interplaying with the family doctor and this and that, like whenever we actually have the opportunity to directly collaborate and kind of build those bridges, like it
Right.
goes really well. And it's like, oh yeah, we actually all
Absolutely.
kind of speak the same language, just when we're kind of all in our different worlds or our different silos, like it's like, I'm not sure what they're doing over there in that chiropractic silo, and what are those pharmacists really doing over there. But when we start to actually communicate, like it's we're all just on the same team, and all just trying to help people. And so I find that those when there are the opportunities to communicate, it generally goes well, and I enjoy it quite a lot.
Yeah, it's it should be about the patient and not not the egos. That the egos go away and collaborate as much as we can. And like you said, it usually goes a whole lot easier when there's a collaboration versus independent advice that well, you can see me, but at the same time you can't see him, and at the same time, because it can mess it. I'm like, come on, let's grow up and get out of that philosophy, and let's be together. So listen, Dr. Rade, it's in respect to your time, I can't get over how humble you are. I really appreciate every time we get to chat and the information that you provide. I don't know if anybody here watching can appreciate the time and effort that it takes to be able to answer questions on the spot like this, and have the pedigree that you have, and the amount of time and the balance and the work-life balance that goes into doing the postgraduate work and all that stuff. I kind of understand it because I'm passionate about learning, and Dr. Bennett as well. But I just want to say this, that and you probably don't hear it enough. And thank you so much for everything that you do, and the time again that we're asking of you to be here tonight. And our listeners, many comments and hearts and thumbs up is because of the time that you're willing to give. So I really appreciate that.
Thank you. Very nice of you to say.
And for those of you who have been watching the entire time, don't forget to share the episode, because we want to be able to help people. That is the reason why we're doing this. It's so that we can connect and help as many people as we can by offering this type of information. So when you have the information, then you then have the tools to use to find yourself the help that you need. So yes, from the bottom of our hearts here at Roach Chiropractic Center, thank you, Dr. Bryan Rade, for talking with everyone tonight. And I think we all learned a thing or two from you. So again, thanks so much.
My best saying is that, the quality of the life you get to live is based on the quality of the questions you get to ask. So, obviously there's quality questions tonight, and I think the quality of the questions you get to ask is based on the knowledge that you have. So, this is what we aim to provide is knowledge and information. So again, thank you so much, Dr. Rade. We're going to be doing this again next month. We'll be promoting it as always. It's going to be a different topic. So again, I appreciate, doing this a third time. And we'll be live next week again at 9 o'clock Atlantic time. And we'll be talking about, we don't know yet, but we'll come up with a topic. So thank you so much for all of you that were live. And if you're watching us on YouTube, thank you so much for being on YouTube. Make sure you subscribe. And right now, everybody that's live, please go ahead and share this episode and, share this information that is so brilliant and free. Where else are you going to get this, right? But Humble Conversation. Thank you so much, Dr. Rade. Thank you so much, Dr. Ben. We will see each other next week again, 9 o'clock on Wednesday. Thank you, guys.
What's up, guys? Listen, if you like this episode, you'll probably like the other ones. Chances are pretty good, so here's what you need to do. You need to like us and follow us on Facebook. Following means you get notified when these two guys are live. Next, family, friends. You need to share these episodes because you never know. You might help them because they need this information as well.
And guys, if you ever miss an episode, make sure you subscribe to us on YouTube. That way you can watch the episode over and over and over again.
Guys, we love you and appreciate you.
Take care.